Hello, everybody, and welcome to the IOCDF Research Roundtable, the IOCDF live stream where we pick an interesting topic within the OCD literature and discuss it with folks who know it well. As always, my name is Kyle King. I am one of your hosts of the show. I am a first-year medical student at the Yale University School of Medicine. But more importantly than that, I am someone who has OCD. So a lot of the things that we talk about, a lot of the research that we discuss on this show pertains very directly to my life and is always super interesting to hear about. I'm joined by my co-host, John Abramowitz. John, if you'd like to say a word or two about yourself.
Thanks, Kyle. I'm John Abramowitz. I'm a professor of psychology and neuroscience at the University of North Carolina at Chapel Hill, and my life's work is dedicated to studying and treating and learning about and teaching people about OCD. So I am very psyched for our show today.
Yeah. Our stream today is going to be about the intersection between OCD and substance use disorder. And it's honestly an intersection that I have not given much thought to, despite having worked in the advocacy community for a long time now. But then we were just discussing it before the show started, and now I'm really jazzed about the topic because Dr. Hoffman specifically made it seem like he has some interesting information to share. I will see if that bears true. Yeah. You made me think so, Dr. Hoffman, so we'll see. But before I introduce our guests and jump into questions, I have a couple general statements that I have to make, general announcements. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org. Or you can go to your local emergency room or call 911. Third, there is a chat function. We love when you put questions in the chat. We love when you put where you're tuning in from in the chat. So please feel free to do so. And if you have questions, we will try to get to as many of them as possible. Just know that this is live and lives on the internet forever. So be respectful in the chat, although we've never had any problems in the past. All right. I think those are all the announcements that I need to make. So I'm going to go ahead and start introducing our guests. I'll start with the person that I already shouted out, Dr. Jonathan Hoffman. Dr. Jonathan Hoffman, PhD, is a licensed psychologist and board certified in behavioral and cognitive psychology. Dr. Hoffman is Chief Clinical Officer at the Neurobehavioral Institute, MBI, and Director of the MBI Ranch. It's also where I was treated for my OCD. He's a member of the IOCDF Scientific and Clinical Advisory Board, co-chair of the OCD and Autism Special Interest Group, and has served as a faculty member for the Behavioral Therapy Training Institute at the IOCDF. His writings and presentations have pertained to many OCD-related topics, most recently OCD and eating disorders, OCD and autism, nonverbal learning disorders, and intrusive thoughts. Dr. Hoffman, how are you doing today?
I'm doing well. Thank you. Thanks for the invite. I'm really looking forward to this discussion. It's a really interesting topic that I've worked in. I didn't mention that in my little brief bio, but I've worked in this area for a lot of years, even predating working with OCD.
Oh, okay. Cool. Then you're a good person to have on. And I did write down what we spoke about before the stream, so I'm expecting some nuggets throughout.
Okay.
I'll move next to our guest, Michael Randazza. I think I got that. Michael is currently a third-year graduate student in the clinical psychology doctoral program at the University of Arkansas. His research centers around the co-occurrence of substance misuse with fear-based disorders, including OCD, PTSD, and social anxiety. His current work examines cognitive constructs affecting the use of substances by those with OCD, the use of protective behavioral strategies, or behaviors which can be utilized by those who use substances to mitigate serious consequences. That was difficult. As well as the impact of substance misuse on learning processes central to therapies for fear-based disorders. So Michael's definitely a good person to have on the stream. Michael, how are you doing?
I'm doing great. Thank you guys so much for inviting me on here.
Are you tuning in from Arkansas?
Yes, I am currently in Arkansas.
I think you might be the first person I've ever met who has lived in or is in Arkansas.
That's not that surprising. I moved here from New York City, and before I came here, I had not met anyone from here either. So
yeah, I mean, it's good to know that it's a real place.
They have an awesome University of Arkansas has an awesome clinical psychology PhD training program that Michael is in. So he's in a very good place.
I'm sure of it. Go Razorbacks. And our third and final guest is Lorena Fernandez de la Cruz. I'd like to put an X in there. She's an associate professor at the Department of Clinical Neuroscience at the Karolinska Institute in Stockholm, Sweden. She is a clinical psychologist trained in Spain, the UK, and Sweden, and has worked as a clinical researcher for the past 15 years. Her current research mainly focuses on the health consequences of OCD and improving the lifestyle habits of folks with the disorder. She also works on the development and dissemination of evidence-based treatments for OCD and related conditions, and has been on the show before and is a friend of the show. Lorena, thanks for joining again. How are you doing?
Thank you very much. I'm very good. Thank you. Yeah, and it's 6 in the evening for me, so I guess good evening. And thank you for having me again. It's a pleasure.
Yeah, it's always fun when you're on the show. I was looking at our other email chains of the last stream you joined, which I think was about the epidemiology of OCD, which is a super cool episode if people want to go check that out. But the past is the past. Let's focus on the present and let's talk about substance use disorder. So before we jump into kind of the intersection, I first want to kind of pitch to the group, what do we mean when I say substance use and misuse? And what is the relationship between substance use and how we think about substance use pathologically? And that's for anyone.
Well, I think you can tell by the silence. It's a complicated question.
Yeah.
What we really mean by it is you could abuse prescription. Are we talking about licit or illicit medications? I'll throw a little twist in there right away. That it's been very interesting to me how what was regarded as illicit is now being promoted as treatment for OCD in some quarters. I think there's been some very interesting paradigm shifts about this. And the relationship is it a problem? Is it a treatment? Is it, something that's just kind of a lifestyle element if some people have OCD? I think there's all these different facets which make it a really fascinating subject and a controversial subject as well, with very strong feelings on all sorts of sides.
And we used to have a distinction between substance abuse and substance dependence in the DSM, right? The big textbook of what's a disorder, And in 2013, when the DSM-5 came out, they did away with this idea. Substance abuse was kind of a less severe version of substance dependence. In substance abuse, the person would use substances, occasionally to deal with certain situations, and it would get in the way of their functioning. Substance dependence, they would spend more time. It's kind of a more severe variant of that. They're spending time, looking for substances and spending a lot of money, and gets in the way of lots of different areas of functioning. And I guess there was some confusion about how to distinguish those two. And so the DSM makers changed that in 2013 in DSM-5. Now we just have these substance use disorders. It's for a little history lesson.
Yeah, I think it really represents where the lines become very blurry between psychological dependence, physical dependence, process addictions, what aspects of OCD on our particular subject are resemble and don't resemble addictive processes, and how. And these lines get very, very fuzzy, and I guess that's how DSM rolls. It says, well, we have these lines. Oh, no, we don't have these lines. Oh, well, the lines are over here. So it's always kind of shifting around. And drugs, they do cross boundaries, so they not only cross the, blood-brain barrier, they cross all of these nosological categories. And what's helpful, what's not helpful, what's just propaganda.
And as you mentioned before, social, there are shifts in kind of the social zeitgeist. For a long time we saw, mushrooms as being illicit, illegal drugs, and now we use them for half of these, DSM mental disorders. I'm not sure about the evidence that we have for that, but they are being used.
Yeah, and I certainly want to get to treatment and the extent to which we can consider drugs, whether that be illicit substances or pharmacologics, as like things that you misuse or things that you use to treat OCD. But before we get there, I kind of just want to, maybe I'll pitch this to Michael or Lorena. What's kind of the epidemiology of the overlap between substance use disorders and OCD?
I mean, I have some of the knowledge in that, but I'm a big fan of one of the papers Dr. Fernandez de la Cruz was a co-author on that subject. So I think I'd let her answer it.
Yeah, well, I mean, I think John now mentioned that that the literature has been. I don't know if you said something similar. There has been, or it was with Jonathan before we started the live stream, that at some point it's been a bit mixed. Like some studies say, oh yeah, there's like a protective effect even because of this risk avoidance, and other studies don't find an increased risk in OCD compared to the general population, and many others do find increased risk. So I guess that the study that Michael is mentioning is a study that we ran a few years ago here in Sweden using this Swedish health population registers, and we were able to study this question looking into 27,000 people with OCD compared to the general population. So I guess that the answer has to be valid somehow, because this is a very, very large sample, taking into account also differences between countries when it comes to, these things that we were discussing, like drugs and what's illicit use and from what age you can use certain substances and so on. But what we found was in line with our hypothesis, actually, which is that people with OCD were 3.7 times more likely to present with substance misuse outcomes compared to the general population. And this was very interesting because we did not only look at substance use related disorders. That's what John was saying, that was used to be in the manuals, like intoxication, abuse, and dependence. But we also wanted to look at other things that are substance use related, but that they are not diagnosis. But for example, substance use related criminal convictions, such as driving under the influence. And we also looked at substance use related deaths. So there are a lot of deaths that can be attributed to the use of alcohol, for example, diseases of the liver or pancreatitis or hepatic failure and things like that. And we found that people with OCD had an increased risk of all these outcomes in general compared to the general population. So I think that this is very telling, and that we can see that even if there are individual differences, as a group, people with OCD do have an increased risk. And obviously this is, now we can discuss, very important for prevention, what to do, how to manage this, the role of comorbidities, the role of the severity of the disorder, the symptoms, or specific symptoms, and so on.
Mm-hmm.
Well, the risk goes kind of both ways, though, right? That you have more of a risk of abusing substances, and you have, because any kind of mental health issue, including OCD, is going to increase your risk of trying to find some answer that might not be very helpful. Plus, just using it increases the risk of creating more damage than for a person who doesn't have those mental health issues, including OCD. So it's kind of a circular and synergistic relationship there when we look at that risk factor.
What do you mean exactly?
Well, because if you have OCD and you're using a substance, you have an increased risk compared to general, compared to other people, because you have already something going on in your brain. So, which might lead you to make some conclusions about how to deal with it, and substances might be one of those things. But when you already have OCD, and perhaps like most people with OCD do, other comorbidities, the use of those drugs is going to impact you in a different way than the next person who doesn't have those issues. So you have those different layers of risk in there. Does that answer your question? But
no, I was going to say, one of the things that I think is notable in the paper Dr. Fernandez de la Cruz was talking about is there is a much higher risk for people diagnosed with OCD for these disorders. But then also when they went back in and controlled for comorbidities, anxiety, depression, everything else that can co-occur with OCD, the risk was pretty much equivalent to the general population for a lot of these.
Interesting. So
Yeah,
I
well,
mean,
it was a bit reduced, but still it's a bit higher still. It was not completely reduced, but it is true that comorbidities also affect the picture here, and I think that tells us that it's very important to manage the comorbidities. Also, in line with what Dr. Hoffman was saying now, we did find a particularly increased risk of sedatives, which it might be a prescription drug that we give our patients because we think it's going to help manage their anxiety. But it might be that because of the symptoms of the OCD or anxiety or other things that people want to deal with, that they are being misused, and I think that this is also important to consider from the management point of view.
Yeah, certainly. I want to briefly return to something Dr. Hoffman said, and get kind of the whole panel's opinion on this. When Dr. Hoffman was explaining kind of the interrelationship between OCD and, maybe seeking out substances, I feel like the implication there is like there's psychological suffering because of OCD, and I seek to nullify that suffering in some way with substances. Is that why we see this increased rate of substance use in folks with OCD?
Well, that's one of the reasons. One of it is just a concurrent lifestyle. And it's always kind of fascinating that someone, on the one hand, when we know there's not logic to this, can be highly, phobic of danger or contamination or some kind of risk on the one hand, and yet use a street drug on the other hand. It seems contradictory, but one of my early experiences in this was working in a heroin program where we treated a fair amount of bodybuilders who were building up their bodies in day and shooting heroin at night. Wow. So there is it does looking for logic in all of this, but so it can be self-medication. It can also be used as a safety signal. I mean, there's no just one answer to all these things. That gets back to, I guess, before we were talking about functionality before the live stream started, that there's different functionality. Some people want a gratification. Some people with OCD, it's an escape for them. Some people, it's to ameliorate depression or anxiety. Some people, it has nothing to do with it whatsoever. They just hang out with their friends and use.
Right.
So
Yeah.
there's not a clear, it has all of these multiple, and it can have more than one functionality as well.
And I think that's just, it's such an important point, because we can look at the data, we can say, oh, there's a high comorbidity rate. But what Jonathan is saying is that the fact that there is a comorbidity rate doesn't tell us all that much. What's even more important, especially if we're going to try to understand, why the person is using and then do some sort of treatment to help them reduce their OCD and the drug use, is really to understand the function of that behavior. What are the antecedents? What are the factors that motivate the use? What are the consequences of the use of the medication? What's the context in which it occurs? And I think very often, we overlook that functionality and we get wrapped up in, what's the comorbidity? It's just really important to look at that more kind of nuanced relationship.
Mm-hmm. But I mean, to some degree, though, like it can be broken down into an empiric question, right? Like, have there been studies that ask folks, what is the primary motive behind this use?
There have been studies that have looked at use motives in a few different substances. I think mostly cannabis, alcohol, and nicotine. And primarily it seems to be for coping, though we don't know specifically from that relationship if it's with OCD symptoms or for other symptoms that were not controlled for. And then some larger studies show some smaller paths for that might revolve around difficulties with social issues, such as conformity or just making social interaction more easier.
Yeah.
Mm. Okay.
And we know, to kind of throw another, variable in the mix, we know that the reasons that people begin to use substances are different than the reasons that they continue to use them. Right? Like Michael was saying, you can get started using substances because of peer pressure. Your friends are doing it, things like that. But then once a person starts, all sorts of other factors come into play, and maybe it becomes an escape. from distress. Maybe there is some sort of positive reinforcement where the person gets some sort of high and they enjoy that feeling, and which could be related to receptors in the brain and things like that. And then other reasons can kind of take over. And so it's also important to understand that those factors may be different.
Yeah. I think I remember learning about that in some psychology class, like the dark side of addiction is when it becomes like trying to know you're no longer, or I guess you're chasing a high rather than like experiencing the positive sides of the high. Does that sound about right?
You're looking to avoid the negative in the curve, in the addiction curve. At first, it might be trying to get an effect, and later on, it's to avoid an effect. And originally, it's more under operant control, and then as time goes on, it becomes like any habit, more under stimulus control. Yeah. And on top of that, whatever the reason that leads you to be misusing or abusing a drug, it doesn't really matter anymore, because then that kind of fades out of the picture, and then it's using the drug is to use the drug. That becomes the issue. So it becomes so we'll probably get into this in treatment. So trying to treat, like, even if the functionality was something originally, thinking that if you solve that problem, you're going to solve the abuse problem, usually kind of as a red herring and regarded as a red herring in drug treatment.
Really? So like treating the initial reason that someone began using a drug doesn't necessarily get to the root of the problem.
Yeah. So if you began because you're insecure and anxiety, and you're going to really examine that, and let's just try to address the problem from that end, that's usually not regarded as sufficient in drug treatment. Not that it can't be an aspect of it, but that's not usually regarded as the core of treating a drug problem, which is abstinence prevention. And that's why they go into like kind of a different model of treatment, as opposed to the personological model, or just dealing with what the person was going through, as opposed to the event of relapse, and like we talk about in relapse prevention. So the paradigm kind of shifts.
Mm-hmm.
Yeah.
Like in AA, for example, AA or NA, they don't ask you why you started. They have a format for keeping you from continuing, and
before we dive too headlong into treatment, though, I kind of want to focus a little bit more on the specifics of the overlap. What's the relationship between severity of OCD symptom and risk for abuse? And Lorena, this seems like maybe a question that would be good for you.
Yeah, I mean, actually, in these registers that we have, we are not able to look into symptom severity, only whether the person has been diagnosed with OCD or not. So we were not able to look into the severity question in this particular study. But I would say, from the scientific point of view, this is very difficult to study as well, because symptom severity, as you probably know, goes up and down depending on different factors like stress, or depending on whether something is going on in your life. And obviously we will need to measure alcohol consumption or drug consumption repeatedly over a certain period of time. I don't know what the others, if others have an impression on this, on symptom severity and substance use.
No simple answers to that.
I mean, that's a really good point. There's a methodology called ecological momentary assessment, right? Where you give people literally like, their phone, and they, when they use the substance, for example, they write down, exactly what they're doing, what's the context, how they're feeling, and or they get primed every, 15 minutes, how are you feeling? What's your urge to use a substance? Things like that. And that, I would doubt we have studies. I'm not aware of any studies on that. Maybe you guys know, but that I think would be really helpful to understand kind of the function that we've been talking about, and when do people use. A hypothesis would be that they're using it when the OCD spikes, but that's different than saying, oh, these people are high on the Y box, right? Because the Y box is a measure over the course of a week or a month, whereas this ecological momentary assessment gets at how are you doing in the moment, which is probably a better predictor.
No, I would definitely agree, because there is some self-report data using the OCIR, and there is, at least a small to moderate correlation, but that's not accounting for other factors that are going on.
Yeah. I'll just throw this out there because I think it's interesting. A lot of this does depend on self-report data, and it's interesting. Is self-report of substances as reliable as self-report of other things? And there are people could self-report. I'm stoned and driving well. I'm drunk and driving well. I mean, there are some things that we have to, as Dr. Fernandez de la Cruz said, these are very complex issues to address in research. But what else are you going to do? Yeah. Because how else would you arrive at this information? So probably as much as real time as possible. But I was reading some things that, when generalized from like studies done at universities or studies done of drugs done in laboratories or animal studies, they're not exactly representative of what actually happens in real life or street life, even street life with drugs and how people are. So the person who's going to actually sit and monitor their substance abuse every 15 minutes, it may not be representative of the population as a whole. So it becomes, again, this is the no easy answer of Research Roundtable. I mean, probably none of them have easy answers, but this particularly is very, very murky.
That's a good point.
Yeah, I guess that is a good point. You go, Lerna.
No, I was going to also go with the self-report that we have to rely on. I mean, I've been studying more recently other lifestyle factors, and we know for certain that people tend to overestimate the amount of physical activity that they do, and they tend to underestimate the weight, or they always report less. So it is interesting to kind of, that it is a fact that either voluntarily kind of not lying, but that you maybe have an opinion of how you look like or what you do, whether people would be honest at reporting, this is the amount of alcohol that I have been drinking, or this is the substances that I have been using. So in a way, when we run all these studies, we know that we have a bias sample, that maybe they are in a place where they want to be helped or where they perceive this as an issue. And it takes a while for some people to acknowledge or to perceive this as an actual issue that they would like to change. So I think that's also important to consider.
Great point.
Yeah.
I
did see that too when I was doing some background research, that there's critiques of this literature in general, that you're talking to people who typically are in an inpatient facility who want to get better, and that's a very different population than the average person just kind of walking around using a substance. John, I don't know if my internet cut out because it's been a little bit shaky. Has there been an ecological monitoring study about substance use and OCD and seeing if there is any prediction with severity?
I mean, my guess is no, but the other three guests might know better than me.
I'm not aware of anything.
Yeah. EMA is kind of a new, and in my opinion, very much underutilized, but it costs a lot of money, and so we don't see a ton of it out there yet.
So the sense that I get as far as severity is concerned is there may be some data that suggests that there's some connection between severity and use, but it's really tentative, and there's a lot of questions about sampling and exactly how much predictive value severity may have.
And it's also OCD theme congruence or incongruence with using substances, because you could find two people who are scrupulous, right? And one of them, their scrupulosity, they would never touch anything. And one of them would say, I have to be scrupulous to my particular cultural belief system, which says you should use marijuana or something. Yeah. So you could find this even within the same symptom kinds of clusters, very, very different outcomes depending on the other contextual factors, other things that are going on in the situation. So it wouldn't necessarily only be perfectionism, scrupulosity, uncertainty tolerance. It depends how that's construed, because it can be construed either aligning or misaligning with the use of substances.
I've seen folks who might have the same presentation of OCD. So unwanted violent unwanted thoughts of losing control and doing violence to people they love. And one person, and I've met people who, when I ask about, substance use, they'll be like, oh, no, I don't use substances. Well, why not? Oh, because that will lower my inhibition. And then I'm going to, maybe in a drunken stupor, go around stabbing people, which is my worst fear. And then you have other people that will say, oh, yeah, I drink to try to get rid of those intrusive thoughts. That takes me to a better place. So, what accounts for that? It's the person's own, and that's, the person's own cognitive factors, and which is just what I find really fascinating about OCD. If you've met one person with OCD, you've met one person with OCD, because everyone just kind of has their own puzzle in the way that their symptoms are kind of fitting together.
Yeah, but John, I'm a college student. I want there to be nice, pretty answers. So I'm going to ask this question, and then I'm probably going to get no nice, pretty answer in response. But on the aggregate, is there relationships between the OCD subtype that we're dealing with and substance use?
Good, great questions. I don't
think this kind of comes back to that problem with self-report data we were talking about earlier. But there have been studies of different subtypes, at least between symmetry and obsessing and ordering and all the different categories. But a lot of them in different studies are more or less tied to substance use, but it always seems to be the obsessing category that's most strongly tied.
Makes sense.
And that, whether it's the type of obsession or if it's the lack of compulsive behavior to regulate, we don't really know at this point.
Okay. Yeah. Could you flesh out what exactly it means when you say like obsession is tied to substance use? Like, what isn't all OCD going to be related to obsession to some degree?
Well, that's the way, at least like the Y-box and the OCIR, some of these self-report scales work is you have different categories where, like in the OCIR, obsessing is pretty much just different types of obsession, whereas the other categories include obsessions that are about either, like we said, contamination, but then also the behavior of cleaning. So the obsessing category, for the most part, tends to represent obsessions generally, and also ones that don't normally come with attached behavioral compulsions.
And is there any hypothesis as to why that link would be slightly stronger?
Not that's been illuminated so far. Like I said, the idea seems to be that they don't employ other behavioral strategies to regulate the distress from the obsessions. But other than that, there's nothing that's been really offered so far.
I would have what everyone thinks, but I think you could find people with every sort of obsessional theme who do and don't use substances, and would have their own individual reasons why that they would, because it's really a constructed narrative about it anyway, right? And so is it really going to be more important to pay attention to the thematic content, or to the process, or to greater issues that we tend to pay attention to in OCD treatment, like the ability to tolerate uncertainty, the ability, these other kinds of things that are more process related, that are going to be more key than exactly what type of obsession you have, because you can see it going both ways with any obsession.
Yeah.
You can see people self-medicating for harm avoidance, right? Or avoiding self-medicating due to harm avoidance. And you can see it the same. You can see it both ways.
Is there any semblance that there's kind of, I feel like a lot of our discussion has been pointing a causal arrow in like the OCD going to, wanting to use a substance to feel some sort of way. Is there any sense that there might be something in the other direction where using a substance may exacerbate OCD?
Sure. You use stimulants. Could all substances, you use a stimulant, it depends on your drug of choice. But I would imagine anytime you're going to be using something for either as a safety signal, as a way of coping that prevents you from using more beneficial ways of coping, that you're going to find that this is deleterious to OCD. This is a net negative for OCD, no matter what.
Yeah.
Which kind of gets into that whole area, is like, why would, people who purport that these certain substances are going to be good for OCD, what would be the theoretical model to support that? Which is something, I don't know if we want to get to today, but I think is a very interesting question.
Mm-hmm.
I have run into a handful of folks who swear that they used hallucinogens and never had OCD before, but then afterwards developed OCD. Mm-hmm. Not a lot of people, but a few folks have said it all started from such and such. And one of them, they got into these philosophical, existential obsessions, right? They had this out of mind experience, whatever you want to say. I'm not a hallucinogen user, though it sounds pretty nice. But then they were like, well, what if what if there's this whole other realm, or what if I'm not real, or what if none of us are real? These existential obsessions, and that came from drug use. I don't know if you all have run into that.
Yeah, absolutely. And you could run into the opposite. You could run into someone with severe OCD and say, until I started tripping, that's what saved me, or that using that. So again, we find ourselves in this kind of
goes both ways
about this. Yeah.
Fascinating.
But was this maintained over time after, your trip was over, or, like all these obsessive thoughts after like using these hallucinogens, did they keep the OCD symptoms for a long time afterwards?
Yeah, the person that I met with, the trip had been years and years ago.
Oh, okay.
Yeah, and that just kind of kicked it off.
Yeah. I've seen that many times.
Yeah, and they had been spending all their time, doing mental rituals, trying to figure it out and all that stuff. And I don't think other treatment providers really got it, really understood. Yeah, but no, it had happened a while.
Do you think that maybe there were some baseline symptoms or some prior vulnerabilities?
Yeah, that's what I would
like a trigger.
Well, right, and it's hard to know because it's self-report. And it's, they could have had mild OCD symptoms or anxiety and just didn't really think about it much until after. And that's the problem with, when we make these claims about the cause, this event happened and then I developed OCD. I went to bed and the next day I developed OCD. Well, okay, but we don't have really strong data to support that. So it's a good question. Yeah.
No, I agree. I think that is very important to study mechanisms, for obvious reasons, and knowing the causes, and in order to, put together preventive efforts and early intervention and so on. But sometimes we get a bit trapped on why am I doing this and why did I develop OCD? And I mean, for example, for the relation between OCD and substance use, we also know that there's a shared genetic etiology there, and that we do have, or certain people have some genes that made them more vulnerable to have both OCD and substance use. And maybe because of that, some people do try drugs and they don't continue, and some other people do try drugs and then they keep using them because of this genetic vulnerability. But we don't really know the why and what comes before and what came after. That's why I think that is very important to pay more attention to the maintenance factors, and once the issues are here, what can we do to solve them? But I understand why we, myself included, try to figure out what's the mechanism and what's the cause and why is this happening. But sometimes it is very difficult to find a cause and to know.
Right. And individual differences are so great. I mean, this is not the nicest analogy, but it is a common one to say what's kind of like Russian roulette. That if you have OCD or any mental health issue and you use substances, you probably can, as we spoke about before, you probably are playing with fire to some extent. But how much fire are you playing with? Do you have one bullet in the chamber, or do you have 2 or 3 bullets in the chamber? And it's very hard to know as an individual. And sometimes you can see these very rapid onsets of OCD with one use of a substance, one bad trip, or things like that. And sometimes people will use persistently, and they have no issues whatsoever. But an analogy that comes to my mind is, you may have heard the saying that for every star on the Hollywood Walk of Fame, there's a million broken hearts. Well, I would say for every movie star, or rap star, I don't have to name names, but who is perfectly fine using a lot, there's a lot of people who've experienced psychosis. There's a lot of people who've had their intellect, a lot of people whose lives were derailed. For these people who are kind of outliers and say, well, nothing happened to me. But that's what those are often the exemplars that people say, well, look at this person. They have 50 movies and they, smoke hot or whatever every single day.
Yeah. And I mean, I kind of want to, like John, you mentioned the use of psilocybin and then that people claiming that led to their OCD. I do want to just mention that out of respect to Chris Pittenger, who is my boss, and does psilocybin work. Like, there's also plenty of people who would say psilocybin helped their OCD quite a bit. So to Dr. Hoffman's point about it going both ways, take any drug and it can go both ways. There's claims that it could go either way.
Well, yeah, but we don't know exactly how that works. It's exactly their claims, but we don't know the exact mechanisms of how that works.
Yeah.
So and that is a huge problem, because the treatment and belief in some of these things, and even the research itself, giving kind of the authentic, giving kind of it a stamp of approval, is kind of an interesting thing as well, because, well, if there wasn't some credence to this, why would prestigious scholars and academic institutions be studying it? There are some very interesting messages. And then it's a question of, cost benefit. Say you have 100 people and 90 kind of are okay with it who have OCD, but you have 10 who are not. Is that worth it? Is that what happens to them? And, and making these kinds of decisions, again, is another layer of a problem here. At what point is it something that may be okay for some, but not okay for others? And do we know enough really to say who? Are we going to be able to?
Well, so we're going to dance around the subject of treatment. So let's just take it up in earnest. What is kind of, for all three of you, and John included, so all four of you, what do you perceive the relationship between substance use and treatment to be? Does it tend to make it way harder to treat OCD? Does it seem to make it sometimes easier? We can talk about the introduction of new drugs like psilocybin and whether or not that seems reasonable, and how do you make that decision if you're a patient? I'll start with you, Dr. Hoffman, since you've kind of been
I can say over the course of my career, the book used to be that if someone was actively using substances, we would not treat them. For OCD,
really?
That was pretty much the prevailing.
Not treat them at all.
Yeah, because there was no point to treating them. They were, they had to commit to some sort of abstinence. That's going back decades. I think the thinking about that has really changed a lot, because people are different, substances are different. There's a more nuanced approach. Can you treat someone for OCD who's kind of like California sober as opposed to actively using? At what point? I mean, there's all these different kinds of things. People are California sober with OCD too. They'll do this ritual, but not that ritual. People pick and choose. So now we have kind of a more individual way of dealing with someone who has OCD and is using substances on a case-by-case basis. And I think the prevailing, and you could all say what you think, but I think the prevailing thought is to try to do an integrated treatment where you're treating OCD and you're treating substance abuse, and looking at the commonalities, some of the differences, but actually trying to go toward a more healthy and productive life, more value-based kinds of things. And that's why ACT has been very prevalent in addressing these issues as well. So looking at this as just kind of a whole way of dealing with life.
Something that I consider when I am working with someone who has both problems, whether to address the OCD or maybe refer them to get help for substance use before working on OCD, is, how much is the substance use going to get in the way of what they need to learn during cognitive behavioral therapy? So you look at something like exposure and response prevention. That's a learning therapy. You have to be, sober in order to learn something from doing exposure and response prevention, in order to learn not to be afraid. That takes processing a lot of information and doing the therapy right. And if someone, is using substances that maybe it's not related to their OCD, or they're using substances related to the OCD as a way of coping with their obsessions, and they can't not use, they have trouble, abstaining, that can get in the way. And it's probably worth getting some help for the substance use first before then transferring over to OCD treatment.
Mm-hmm. Yeah, I agree. I was thinking exactly the same, that many of you that are listening, you know how difficult treatment for OCD is, and it requires such an effort, and you do really need to learn, your brain needs to learn, like processes that we are not even aware. And if you are using substances at the moment, all that work, probably is not going to be as good. So it may be better to intervene on the substance use disorder first. Obviously, then if the obsessions and compulsions are too interfering, that doesn't mean that an intervention cannot be going on in parallel, but proper ERP requires a lot of effort, and that means that maybe other things need to be looked into first.
It also gives kind of a very mixed, I agree totally with what both were saying. It also gives a rather mixed messages about distress tolerance, uncertainty tolerance. Well, that only counts for my OCD. It doesn't account in general as if your brain is going to be able to make those different kinds of differentiations, like as if it's all not of a piece and you can pick and choose. And it gets into some very interesting conversations. At what point do you say, well, let's treat this drug first, or we'll try to do both of these together, or we'll just try to take like a minimize harm approach. We'll try to reduce the drug to where it's less of a problem. And again, it's not one size fits all, and people are different, and so we have to just kind of as John was saying, just kind of really look in each individual case what would be the most effective approach.
Yeah. So it seems like the field has grown a lot more open to treating folks who are currently using drugs or using some sort of substance, treating them for their OCD. But generally speaking, it's desired that person has stopped using substances so that they can really benefit from the ERP as best as possible.
Well, the legal regulations have changed a lot also. So, that's become a factor as well. And people tend to confuse legal with safe and effective. But a lot of things are legal now that weren't, just a short while ago. So the arguments about it become very different. The consequences of use become very different. So these are all, again, contextual factors that have to be taken into consideration. What the person does for a living. Are you a pilot, a police officer? You in the military? You work at a nuclear plant or something different? There's a lot that goes into this kind of decision making if you're trying to be, really have a due diligence about it.
Yeah. And I think now when you say that things have changed recently, and some things that were not legal before, now they are. Alcohol is also legal. If you're in the US, I think it's over 21. Tobacco is legal. So that doesn't mean that it's desirable for you to use it, and we know that it's linked to a lot of health consequences. So I think that goes on the decision making of every individual, that the fact that it's available, that is there, that you can buy it, doesn't mean anything. And sometimes it feels that we romanticize the use of certain substances, so that is very cool now, to smoke cannabis, or let's try this because it's hallucinogen. I've heard these things, and I think that the responsible use of substances or no use, it's also something that we need to consider, of course.
Well, that's kind of a topic I wanted to bring up. Like, how do you, as experts in this conversation, like have that conversation with a patient who's like, hey, I want to try cannabis for my OCD, or hey, I want to try ketamine. Like, what goes into making that decision if that's a good idea for a patient?
I talk about the science. I never tell people what to do. That's not my role. I give them, we talk about maybe pros and cons. We talk about what the science suggests to the extent that we know it, and then help the person to arrive at, what might be beneficial for them. But then they get to make, I work with adults, right? So they get to make up their own mind about what they ultimately do.
Yeah.
It's a great question, because this comes up a lot, and it's a question I know where I work where we're asked quite a bit. Well, I read this, or this doctor told me, or this therapist told me. People are prescribing many of the things that other people would say no. So it becomes kind of like, who's right? Who do you want to hear? And as John said, we're not here to be judgmental or to tell people what to do, but to say, as far as we know, these are the risks. Let's talk about it. Let's have an open communication about it. Let's decide. Let's see what happens. We could tell you what what other people have found. We could tell you some anecdotes. We could tell you what we would suggest. But you're going to be, especially, of course, with adults, you're going to be making a decision. But then when you have a 13 or 14-year-old or 15-year-old with asking the same question and maybe receiving very different messages from different practitioners and different people in their environment, or from parents, or from different kinds of things, it just becomes, again, another complexity of dealing with this.
Yeah. How much do you bring in a parent? If a 14 or 15-year-old is talking about drug use, then you have an ethical issue, because on the one hand, right, you're supposed to keep things confidential with your patients, with your clients. But if the child is doing something to endanger them, when do you break that confidentiality? It's not a black and white.
And when is it endangering? At what level do you say it, especially with legal changes? And what if the parent is pretty much involved in that themselves?
Exactly. That's right. Yeah.
So it becomes kind of right.
It can get very complicated very quickly.
Yeah, certainly. Especially when it comes to a minor who thinks that they're expressing kind of themselves authentically and trying to be as open in a confidential relationship. And then, you as a therapist can turn around and tell the parents something that they don't want the parents to know, and all of a sudden the relationship's gone. Michael, I wanted to give you a chance to talk, since you research fear-based learning a lot. Kind of what thoughts were running through your head during that discussion of, how substance use may get in the way of relearning if in ERP treatment?
It's again, like everything we were talking about before, very complicated. A lot of the trials in humans are very mixed on the results, and there's some newer computer models that have shown that people who are intoxicated or potentially have long-term effects of substance use could take several more repetitions of whatever it is we're working on to actually learn at a level equivalent with people who do not have experience with substances, or who are not acutely intoxicated. So it seems like the learning does happen. It just would take longer for that process to take place.
Mm-hmm.
Interesting.
Yeah, and that was figured out by computer model? Like, I don't even understand how that would happen.
Well, there's modeling connections between the different brain areas that are associated with learning, but I don't want to take too much of the talk going between that.
Yeah, well, I mean, it's interesting nonetheless. I also wanted to pitch something. So as I said at the beginning of treatment, or at the beginning of this live stream, I was treated at the place where Dr. Hoffman works, and there I was told something which helped me conceptualize my condition a lot, which was, you can think about OCD almost as a substance use disorder in a sense, because it's like I have this thought, and then the compulsion is akin to like reaching for a drink or reaching for a needle. It's a way to alleviate some anxiety very quickly when I have that anxiety rush. So I kind of wanted to pitch to the whole group, to what extent does substance use disorder and OCD seem to be maintained by very similar psychological mechanisms?
Well, I can say that people have really thought about this subject, and the differentiating factor originally was pleasure. That, they would say, well, they have a lot of similarities, but you have gratification and more pleasure from substances, but you don't get any of that from OCD. But one of the problems I think in the field in general is mixing colloquial terms like pleasure with more scientific terms, because it is pleasurable to avoid a consequence. When you do a compulsion, you're not getting anxiety, and that can be construed as a certain sort of pleasure in itself. And I think this is where we get into just a whole different kinds of things, like, and what's causing versus what's maintaining a symptom. If we're going to say that the kind of cycle that you see in OCD is very similar to the cycle you see in addiction in substance, yes, that's true. There are some qualitative differences that people would point to, but I think there are some unified things in terms of how the symptom that you're doing something that makes you feel better for the moment but makes your situation worse in the long term. I think there's an overarching similarity in that kind of worsening, self-perpetuating vicious cycle for both. But you can kind of quibble about whether the phenomenology, the inner perception of it is somewhat different, and the motivations are somewhat different, and things like that. But you know what? At the end of the day, a lot of it starts to meld into the kind of the same thing, that fixes that make things worse. I would just sum.
Yeah, John, I agree 100% with what you're saying. A lot of it does kind of get, OCD is about trying to reduce anxiety, about uncertainty. In most cases, OCD is so heterogeneous, so I shouldn't make a generalization like that. But yeah, it's about trying to reduce the stress. And person with OCD does compulsions, person with substance use substances. There are important differences. There are important cognitive differences. There are important differences in what substances do and how they're maintained. But I would agree. You can definitely see some mechanistic overlap in what's going on in some way.
I agree with everything everyone has said so far. And there's also changes in substance use that people have looked at in terms of dimensions of impulsivity and compulsivity, where especially over time, drug use seems to be more compulsive and align more readily with certain aspects of OCD once it gets to a stage where it's more severe.
I guess that was kind of.
I was going to say this kind of a border between impulsivity at one end and compulsivity at the other end isn't exactly correct either, because there are impulsive aspects to OCD and very compulsive aspects to impulsively using drugs. Someone could impulsively use drugs, but be meticulous about how they got them and how they set them up for use and the way they use them. So a lot of these boundary areas they're very artificial.
Yeah. I was going to say, Jonathan, there's one thing that I talk about in support groups a lot is like how to know when a thought is an OCD thought versus just kind of like a Kyle thought per se. And a lot of it comes down to like, how urgent does it feel? And you could maybe even say like to what degree is that an impulsive? Like I need to go do this thing right now. Just to comment on kind of that boundary between compulsive and impulsive, and to what degree is that a fabricated distinction? We're running out of time, so I want to give each panelist just a chance to say, okay, we just talked for an hour about this intersection. What's the one thing that I want someone to take away from this honestly pretty like heady discussion? And I'll start with you, Lorena. I picked you.
Yeah, I just want to say, because this is probably the topic I'm focusing more recently, that we are now talking about how this impacts the symptoms, and I want to think more about the long-term consequences and all these health-related problems that I was mentioning at the beginning when I was talking about this study that we wrote a few years ago. That we do know that the use of alcohol and the use of drug is responsible for like a lot of health-related problems in people with OCD, and then may lead to fatal outcomes like deaths because the body obviously doesn't like the substances, and also due to accidents, suicides that may also be related with the use of substances. So I think that we also need to think about these more long-term consequences of the use. That would be my message.
Yes, I definitely agree with what Lorena said. And I think something else that's important to point out is most studies looking at substance use people with OCD also try to look at the difference with how long it took people to get into effective treatment. And for people who use substances, that tends to be a lot longer, by average of sometimes a decade or so. So people are trying to use substances to deal with their OCD and not really getting into what would be an effective long-term strategy for managing their symptoms.
And I just like to, I'd like to give kind of a shout out to IOCDF, and I really appreciate the opportunity to discuss this subject. And maybe this is not going to come out right, but it took a while for IOCDF to get into drugs, so to speak, I guess. So it was only a few years ago that we started having roundtables, which I was kind of honored to be a panelist on multiple times, town halls on what was then a very under-discussed topic of OCD and substance abuse. And since then, there is a SIG, I just want to make people aware of that, about OCD and substance abuse, that is has a lot of great people involved in it. And just that this subject really took a while, like many things. First it was just OCD, and now, as OCD, it's become other subjects that intertwine. So I think it's been a really, this is a problem for so many people. Maybe when we look at percentages, they're kind of misleading. Although the lifetime prevalence, my understanding, is around 25% if you aggregate all the studies for substance or alcohol or substance. It's higher in BDD considerably as well. And it really correlates with a lot of other issues that are, I guess, beyond just this discussion, but would be worthy of further discussion. But I think IOCDF now has become a great place to discuss this issue and get current and accurate information, so you can make your own decisions in life.
Amen.
Yeah, I will say this is an under-discussed topic still, and I'm glad that we had this roundtable.
This has been a great discussion, y'all. Yeah.
To put a bow on things, the IOCDF is a donor-supported nonprofit organization, so please, if you're so inclined, consider making a donation at iocdf.org/donate. And the 30th annual conference is coming up. It's going to be held in July, and you can register and get more information about that at iocdf.org/OCDCon. Thank you to my panelists. Thank you, John, for being a co-host. And we will see you next month.
Take care, everybody. Great discussion.
Thank you.